Hello, good morning. My name's Michael White. I am a surgical oncologist here at St. Mary's Hospital with the Bon Secours Medical Group. I am here today to talk a little bit about colon and rectal cancers and colorectal cancer awareness. Colon and rectal cancers is definitely one of my interests. I do take care of a variety of different cancer types in the abdomen as well as outside of the abdomen, but colon and rectal cancer has always been one of my main interests, and I think there's a lot of new and emerging treatment options for people with colon and rectal cancer, and so I wanted to talk a little bit about some of that today, and I wanted to see what questions we had from the audience as well. As I'm sure many of you are aware, this is Colorectal Cancer Awareness Month. There are a lot of interesting data out there currently about colon cancer. We do know that it is one of the major cancers that afflicts people in the United States. It's typically thought of as the third most common cancer in both men and women, and one of the leading killers as well. However, over time, our incidence of colon cancer is actually going down, as well as the mortality from colon cancer is going down. And in large part, that's due to a couple of things. One, our treatments are better. We have better chemotherapies, better surgical techniques. But I think one of the most important things is that we've done a better job of screening people and catching either cancers before they become a cancer or in catching them in earlier stages where we know that people do better. And so that highlights, I think, really the importance of being involved with your primary care physician, your gastroenterologist, or a colorectal surgeon, and having routine screening colonoscopies as is recommended. In general, we recommend people start having colonoscopies at the age of 50, unless there's some other indicating factors such as a known inflammatory bowel disease, a very strong family history of people getting colon cancers at a young age. There is approximately about 20% of colon cancers that are related to some sort of familial component, meaning either an inherited disease or some genetic syndrome that's passed down. And so in those patients, we have even stronger screening guidelines and recommendations that could potentially start before the age of 50. I'm sure many of you have seen in the news and on TV recently that the incidence of colon cancer is actually increasing in patients that are under the age of 50. And it'll be interesting to see over time if that impacts the screening guidelines. The explanation for that is not 100% certain at this point in time, but we are seeing a dramatic increase in incidence in younger patients getting colon cancer, and that can be people in their 20s and 30s and 40s. So if you are having symptoms of decreased caliber of your stools, blood in your stools, abdominal pain that won't go away, weight loss, things like that, it is important to be seen by a physician because that's something that should be considered and can be evaluated with a colonoscopy or potentially other abdominal imaging. One of the things I wanted to talk a little bit about today was sort of the advent of technology in surgery. I know many people ask and are aware of the fact that we do surgically through minimally invasive approaches now using either robotic techniques or laparoscopic techniques, and there's been a lot of trials and studies looking at these, and we know that these are safe and effective methods for treating colon cancers from a surgical standpoint for people with colon and rectal cancers. And that's been great because typically when we do these operations through a minimally invasive approach, we're doing it with smaller incisions so people have less postoperative pain, their hospital stays are shorter, they have less problems with wound infections or complications. But we're still giving them a good cancer operation or a good oncologic operation, meaning that we're able to still do the same type of operation, but just do it through a less invasive means. And so I think that's something that is really exciting for patients, and that we can do these operations and have people getting home much more quickly, back to their families, back to their regular way of life. Here at Bon Secours, we do offer both robotic and laparoscopic approaches to these operations, and that's something that I think we do very well. Additionally, I wanted to talk a little bit about metastatic disease with colon cancer. Often when patients hear the term metastatic, which means that your cancer has spread from its initial location to a site outside of that, it's often thought of as, well, now my cancer's incurable and not something that can be adequately treated. We know with colon cancer, one of the most common places for cancer to spread is to the liver, and through various studies and trials, we've learned that you can often do surgical resections for these patients still with the intent for cure. About 20 to 30% of patients that present with colon cancer will have metastatic disease at the time they present. And so that has to be considered when developing the treatment algorithm for patients. That's why it's important when you see your physician that they be involved in a multidisciplinary discussion that involves medical oncologists, radiation oncologists, radiologists, pathologists, surgeons, and other physicians as well, including GI doctors, in order to develop the best treatment plan. Eventually, up to about 50 to 60% of people that do have colon cancer will develop metastatic disease over time. And so the importance is to try to identify this early and to see if it can be treated. We do offer liver resections, both through minimally invasive approaches and sometimes through more traditional open incisions for treatment of these diseases. And there's more treatment modalities that are developing and being studied at this time, including ablative therapies using microwave energy to ablate tumors, as well as embolization therapies that are often done by the interventional radiologist to deliver radiation to these tumors. And there is traditional radiation options as well. So there's a lot of treatment algorithms that need to be assessed in any patient that presents with colon cancer.
What is a surgical resection?
So a surgical resection is a term meaning a patient undergoes surgery in order to remove their cancer. Typically with colon cancer, that involves removing a segment of the colon as well as the draining lymph nodes and blood supply to that area. We do that because one, it gives us an adequate margin of resection, meaning that we've removed some normal tissue around the cancer to ensure that we have good margin or resection around that. And then also we want to remove the lymph nodes because the lymph nodes are often the first place that colon cancer spreads. It gives us an idea of the stage of the cancer or how aggressive the cancer is by being able to evaluate those lymph nodes. And then additionally, sometimes if there's just limited disease in the lymph nodes, we can remove that, and with the addition of chemotherapy, have a good chance or success rate for cure in those patients.
What's the difference between the robotic techniques and the laparoscopic techniques, or are they the same thing?
So robotics and laparoscopic techniques essentially are both minimally invasive approaches, meaning when I say minimally invasive, I mean typically that we're making smaller incisions in the abdomen to do these operations. But they're just two different tools in order to achieve the same end, which is that good surgical resection, meaning that we've removed the area of the cancer, the draining lymph nodes, and then been able to put things back together. Robotics is a newer emerging technique in that it uses an actual robot that's controlled by the surgeon. The robot allows for some finer movements in the abdomen and additional reach and things that are nice from a technical standpoint. Laparoscopic surgery also has its advantages as well. It's a little bit more traditional technique that's been around a little bit longer. They both have their advantages and disadvantages, and in my opinion, I think whichever technique is most comfortable to the surgeon is probably the best option. But in general, they're studied, and there hasn't been any significant difference in outcome between those two approaches and minimally invasive operative approaches to colon cancer.
What are polyps in the colon?
So polyps are essentially outpouchings of your mucosa, which is the inner lining of the colon that develop over time. There are different types of polyps, but there are several forms of polyps that can be precancerous, or essentially will develop into a colon cancer over time if left in place. These adenomatous type polyps are one of the main reasons that we perform colonoscopies, because these can be removed often with an endoscopic procedure, meaning that via a colonoscopy, without having to undergo a bigger operation. These polyps can be removed and then assessed by a pathologist, and if there is cancer there, then potentially additional treatment is needed. But often these polyps can be removed at an early stage before they're able to develop into cancer. This process does take several years usually to take place, which is why we have certain time intervals or spacing intervals for colonoscopy. Polyps are something that are seen in many patients as they get older. And so, having polyps is not necessarily something that, patients should get extremely concerned about, but it is a reason to continue with your colonoscopies and screenings, because having polyps and having more polyps or larger polyps does put you at a higher risk of development of colon cancer in the future. Do we have any other questions, or?
That's all the questions.
All right. If you have any further questions about colon cancer or treatments for colon cancer, obviously there are several physicians here at Bon Secours that would be happy to see you and try to answer any questions that you might have. I think the future for colon cancer is actually bright, and that we've noticed over the last 20 to 30 years a lot of improvements, and in large part, as I mentioned, that's due to improved screening. So it's really important both from the physician side to stay on top of screening for their patients, but also from the patient side to follow through and to see your physician so that you can be referred for these procedures. Additionally, as I mentioned, there's newer and emerging technologies, both for treatment of the local disease, meaning the cancer in your colon, as well as for metastatic disease, so sites, either in the liver or outside of that, that have really improved patient outcomes over time. And I think as time goes on, and as chemotherapy and targeted therapies for different cancers improve, we're going to continue to see a lot of positive outcomes and a lot of improvement in our overall treatment of this cancer.
We have a question. Where is your practice located?
So my practice is in the medical office building, the North Medical Office building for St. Mary's. I'm in office 406. St. Mary's Hospital is at 5855 Bremo Road in the, I guess this is considered the near west end of Richmond. We also have, I see patients down at St. Francis Hospital on the south side in the Midlothian area as well. So I look forward to seeing any of you in the future if you need. Hopefully you never need to see me, but if you do, I'm always happy to take care of you. All right. Thank you and have a nice day.